Thank you. Most of patients with acute SRT segment elevation MI have non-occlusive thrombosis. Thus, the removal of thrombus before stenting the infarct artery is a reasonable approach, considering that fragmentation and distal embolization may result in less myocardial salvage, no flow, and also a high mortality rate. Currently, the guidelines recommend with the class 2 the routine use of manual aspiration catheter, and this is a very naive procedure, and is supported, this indication is supported by the result of a lot of trial, but mainly by the TAPAS trial, because the other trial were single-center small trial. This was a single-center trial, but with more than 1,000 patients. And in this study, manual aspiration catheter before stenting was compared with standard PCI that included, in all cases, predilation before stenting. The primary endpoint of this study was myocardial blush, and the patient randomized to thrombus aspiration had a higher incidence of myocardial blush 3, thus a normal microvessel reperfusion as compared to the control arm. And associated with this, there is also the favorable result of SRT segment elevation resolution that was more frequent, complete SRT segment resolution in the manual aspiration arm as compared to the control arm. More importantly, at 1 year, a patient randomized to manual aspiration thrombectomy had a lower mortality rate as compared to the control arm. And however, there are several concerns with this study. The first is that the study was not powered for mortality. The second one is a concern related to the design of the study. Since the majority of patients randomized to manual aspiration had diet stenting without pre or post dilation, conversely, patients who were randomized to standard PCI had in all cases balloon inflation before stenting. And this may be a concern that favored diet stenting in the study arm, favored the manual aspiration. Another point is that the aspiration catheter have a very high profile, and this catheter cannot cross or are not indicated for complex anatomy such as tortuosus or calcified vessels. And in these studies, 10% of patients were excluded from randomization because of this complex anatomy. For randomized patients to manual aspiration, there was a lot of patients who did not, despite the crossing and aspiration, could retrieve any microscopic debris. Thus, overall, 40% of patients who are treated or have the intention to treat with manual aspiration have a completely ineffective treatment. And again, if you try to link the effect of manual aspiration to survival or hypothesized survival, you have to show that this link is improved myocardial salvage and smaller myocardial infarction. However, all the study using manual aspiration catheter, including also the TAPAS trial, where infarct size was assessed by CK determination, did not show any improvement in infarct size with manual aspiration. And the last study using manual aspiration catheter was the INFUSE-AMI, and in this randomized trial, including nearly 500 patients, manual aspiration was not associated with any effect on myocardial salvage as assessed by infarct size by MRI. Beyond the manual aspiration catheter, there is also the availability of mechanical thrombectomy, and these are very few catheter, very few devices. Some of these are not more available, and the more used is the Rheolytic thrombectomy catheter. This is a very important device, since it's a high-tech device that allows the formation of a saline jet through side holes of a small profile catheter for French catheter with a very, very high velocity, more than 400 miles per hour, and at a very low pressure, that there is not injury of the vessel wall. At the same time, this lateral jet create for the Bernoulli effect, fragmentation and aspiration at the same time. The last study using, the last randomized study using this device was made just 2 or 3 years ago, and this study included was a multi-center international study that compared Rheolytic thrombectomy with standard treatment, but differently from the TAPAS trial. We make the standard treatment as the top of treatment, including the same stent for both arms, including direct stenting in all cases should be attempted, and the adjunctive pharmacological therapy included abciximab. Thus, we compared Rheolytic thrombectomy before direct stenting with direct stenting alone, with on top of adjunctive pharmacological therapy, and this study provided a strong benefit, strong clinical benefit in terms of death, myocardial infarction, TVR, and also in the composite point of major adverse cardiovascular event. And these are the event-free survival curve of the two arms. The red is angiojet, and the green is the control arm. Very importantly, a multivariable analysis showed that the randomization to Rheolytic thrombectomy was a predictor of early ST segment resolution with a node ratio of 1.70, and at the same time, randomization to Rheolytic thrombectomy was an independent predictor of MACE with a strong reduction in the risk of MACE with a nasal risk of 0.50. Sorry. I can go back. Go back? Ah, okay. Thus, we, considering all this concern of manual aspiration and the result and our experience with the angiojet, we designed a randomized study comparing the two devices, manual aspiration and angiojet, in patients with acute ST segment elevation MI. And for the first time, we compared the efficacy of the two devices by OCT. OCT should be performed after thrombectomy and before stenting, and was not allowed any OCT examination after seeing the result of a thrombectomy. And OCT was repeated at 6 months to look at the possible effect of the type of thrombectomy on good expansion and of the stent and decrease rate of malapposition. These are some image of OCT in acute MI, and these are all the measurements that we made. The primary point was the number of quadrants containing thrombus. And another unique feature of this study, differently from previous studies on primary PCI, that we included all patients, including cardiogenic shock or very elderly patients or very difficult anatomies. We randomized 80 AMI patients, and we have occurs also secondary endpoint that are the classic markers, angiographic markers of reperfusion, and also SRT segment resolution. These are the baseline characteristics of these patients. You see that the mean age was at least 5 years more than recent primary PCI trial, suggesting that this was a real-world population. We had 5% of patients with cardiogenic shock on admission. Most of the patients had the totally occluded vessel at baseline angiography, such that the pre-PCI thrombus grade was nearly more than 4. The thrombectomy device, the rheolytic thrombectomy device, could cross the lesion in all cases, while predilation was needed for the manual aspiration catheter. And we could, after thrombectomy, achieve a normal TIMI grade flow in most of the patients in both arms. However, TIMI grade 3 flow rate was higher, 87% in the rheolytic thrombectomy arm as compared to manual aspiration. And again, the post-thrombectomy TIMI thrombus grade was lower, 1.6 in the rheolytic thrombectomy as compared to the 2.4 of manual aspiration. Most of the patients in both arms have direct stenting, that there is not the confounding effect of predilation or post-dilation, and the final TIMI flow grade 3 was achieved in 95% of patients in the rheolytic thrombectomy arm and 80% in the manual aspiration arm. Again, TIMI blush grade 3 rate was higher in the rheolytic thrombectomy arm, 72% versus 50%. And again, a strong trend towards more frequent SRT segment resolution, that is a strong marker of the efficacy of reperfusion, was more frequent in the rheolytic thrombectomy arm. And these are the OCT results. In my view, the most relevant finding is that all but one patient had residual thrombus after manual aspiration or rheolytic thrombectomy. Thus, this means that we cannot, with the available device, remove completely the thrombus. Regarding the primary endpoint, there was a strong trend favoring rheolytic thrombectomy with a low number of quadrant, 53 the median value, containing thrombus versus 65. But if we look at the large residual thrombus, that means the number of quadrants containing thrombus over the median value, the difference is highly significant. This means that all patients had residual thrombus, but larger residual thrombus could be seen mainly in the manual aspiration arm. No difference in the characteristics of the thrombus between arms. Thus, we have a very effective device that is AngioJet. However, this effective device is not sufficient to remove completely the thrombus. I would like to show this. Cannot run. Should be automatic. It's not working. But no picture can. I apologize for this delay. I will choose to take directly this, but it's very long. This is, I don't know if you can appreciate. This is not the case. I will kill you. This is not the case. Well,
I suggest that tomorrow you present
no, but just to show you, This is a case with an acute anterior myocardial infarction that was treated with repeat manual aspiration passages with the export catheter. And sorry, this is another case. Terrible. Well, just this case. This is a patient who was treated more than 10 years ago. And this patient was admitted for cardiogenic shock and anterior myocardial infarction. And but there is really a problem here. The patient had a history of bypass surgery and had the total occlusion of venous graft. The cardiogenic shock was due to the fact that these grafts provide blood to the LED system and also through the retrograde flow to the circ. And if you try to treat, for example, this large burden of thrombus with manual aspiration, it's very likely that you will have a fatal no flow, an immediate fatal no flow. And this is the result after the angiojet thrombectomy. And you can see that after thrombectomy, there is only a focal lesion that could be treated directly with direct stent. And it would be also useful to see another couple of cases that were identical with the same baseline angiographic parameter treated with unsuccessful manual thrombectomy and with angiojet thrombectomy. Thus, these are my... No, this doesn't work. Doesn't work. That is my conclusion, that manual aspiration or angiojet thrombectomy allow only incomplete removal of thrombus. However, rheolytic thrombectomy as compared to manual aspiration is more effective in thrombus removal and is associated with a better myocardial reperfusion. Thank you for your attention, and I apologize for this technical problem.
I wanted to ask you, I mean, unfortunately, the Angiojet is not available everywhere. I don't know how many centers have it in Egypt, but the UK also, there are many. What is the policy you recommend for acute MI patient? This has been always a great debate when you write the guidelines. There is one trial that shows mortality benefit extended to more than 1 year, and at the same time, 40% of the times you aspirate nothing. So
yes, again, this is the problem of the quality of procedure. You may have the best device, but if you're not able to use correctly this device, you may be harmful. However, also for manual aspiration, there is a lot of negative trials. Despite this, there is a 2A or 2B recommendation from routine use of manual aspiration catheter. But my question is, I will use, for example, a drug-eluting stent that is associated with 40% of stenosis? I think no. Thus, or you don't use manual aspiration catheter directly, and you make your stenting, your standard procedure, but if you think that you have to remove the thrombus, you have to use the more effective device. This is my policy.
I tell you what we are doing. We are doing a lot of primary 2 to 3 cases per day. We are doing if we have a visible thrombus, we have to aspirate whatever the result is. If we know visible thrombus and do pre-dilate and do put stenting. We started to do angiojet as a pilot, then we discarded the angiojet because it's very expensive for us in Egypt. But I started to do it, but in Angiojet, we use it in all thrombus, not in new thrombus, newly formed thrombus. We do few cases with clearway catheters, which would like the INFUSE-AMI, with very good results in such patients. Are you using the clearway in your center?
Yes, I know very well.
So I think it's if you go with what you say, I think the clearway is the winner, and then if not, the export cath or diver C, the second one. Then I ask a question.
Yes, but why you use the export catheter when you know very well that it's impossible to remove completely the thrombus?
No, if it's impossible, we don't have Angiojet now. We try to aspirate to whatever we can and when distorted the thrombus, and then if the ectasia of the vessels, we inject glycoprotein 2b3 intracoronary in such kind of patients, and sometimes we leave the patient overnight, and the second day the thrombus will dissolve. Sometimes there is no stenting at these patients, such kind of patients. Usually when there is an ectasia, but if you have a small vessel or moderate vessel size, 95% of the patient will succeed to remove the thrombus with. You should spend time. You should spend time in doing the thrombus, even distal. You can use it.
Yes, but if you spend time, sorry, because I have also a lot of experience with manual aspiration. We published a work in JAMA in 2005 with the Emerald investigator. I was one of the principal investigators, and we could retrieve with manual aspiration macro debris in 70% of cases. But if you look at the vessel with the OCT, also spending time, you're spending time in create more and more embolism. Each passage is an embolism. Thus, this is the reality. Thus, I think that if you think that a reasonable approach to remove the thrombus before stenting, whatever the dimension of a thrombus that is invariably present in all cases, also if you have a normal appearance angiographically, if you put the OCT catheter, you will see a lot of material.
But I mean, if you want to differentiate, you should differentiate by cardiac MRI, not by the OCT, because the final is the thrombus where it goes, not inside the wall, where it goes. It goes inside the myocardium. If you don't have a bad MRI, so you are successful. That's why the INFUSE-AMI.
The INFUSE-AMI that uses the clearway catheter, randomized before patient to manual aspiration or not, and there was no effect with MRI of patient randomized to manual aspiration on infarct size and microvascular obstruction. That is, in my view, is clearly demonstrated that at least is inadequate manual aspiration catheter. It's very cheaper, okay. It apparently is friendly to use, but it's not true.
What do you do in UK?
I don't know in the UK. I mean, my personal practice, I tend to use quite often manual thrombectomy, and the only cases when I don't use is when with the wire I achieve a clear focal lesion without visible thrombus. Otherwise, if there is any doubt, you tend to follow what you know is not perfect practice, but is somewhat better. There is also an OCT trial from the Thorax Center showing slightly less material inside after the stent deployment inside the stent if you do manual thrombectomy before, even if there is no clinical improvement.
Of 19 patients, and they showed that there was a lot of residual thrombus after manual aspiration.
Yeah, I think it's important to be aware of that. Any question from the floor? Yes.
Thank you. Now, how important is using a transit catheter to opacify the vessel distal to a total occlusion in the setting of STEMI? And when a large thrombus burden is seen, is it advisable to infuse adenosine, for instance, to protect against no reflow?
When you are sure that you will not be able to remove the thrombus, the right approach is to have available the device to remove the thrombus, including also a covered stent, for example. there are very promising results with this pseudo-covalent stent, that is the MGAR, yes, the MGAR stent. But if you have really a giant thrombus and you are not able to remove it, I think that initial conservative strategy with the infusion of 2B3 inhibitors and heparin for 2, 3, 4 days may be useful.
In the TAPAS study and in the guidelines, it is recommended to use the manual aspiration regardless the presence or absence of a thrombus if the patient having coronary TMS flow. So would you suggest, Dr. Di Mario, Dr. Antioniucci, to use the manual aspiration in the absence of thrombus in patients with STEMI?
Well, I don't use manual aspiration routinely, only for clinical investigation. Thus, we use routinely angiojet catheter, routinely from 15 years. Also with the old stiff 5 French catheter we had, such as showed partially in this presentation, tremendous result. I have cases, for example, of total acute thrombotic occlusion starting from the origin of the iliac to in patients with multiple stents, of course. And it is possible to remove completely more than 65 70 centimeters of thrombus. Thus, the device is out of discussion. It's very expensive. This is concern. But if you want really to remove the thrombus, you have to use the more effective device, in my view.
I think the answer to your question is quite simple. With OCT, there is always thrombus. The issue is how much it is. And I think if you are in doubt that there is a reasonable burden of thrombus, you use whatever is available. I fully agree, however, with Dr. Antioniucci that there are many instances where removing with a manual thrombectomy catheter is so inefficient that the potential advantage is limited. One advantage, however, if you have no flow when you pass your wire, is that most of the time you will have some flow, so you will know where to implant your stent, and you will spare the need for a balloon dilatation that is probably more damaging than passing the embolectomy catheter. That's my empirical strategy.
Yes, and we have to say also if you have not a giant thrombus, also direct stenting is a very good policy. Direct stenting with not too much high balloon inflation pressure, because this is a perfect model of no reflow using very high pressure for stent expansion. But the jet stent trial, the trial was negative for the primary endpoint, for the 2 primary endpoints, because 1 primary endpoint was achieved. And however, this was due mainly because the control arm that included all patients with direct stenting did very well with direct stenting alone.